Wait. You're telling me that when I swallow a pill, the liver intercepts it and destroys most of it before it even reaches my blood? The dose on the bottle is wrong?
Not destroys, metabolizes. But for oral morphine, the liver processes 70 to 80% before it ever reaches systemic circulation. You swallow 100 milligrams, 30 milligrams do the work. The rest is liver activity.
The drug company knows this, doses to compensate, and charges you for the portion the liver burns. You are paying for drug that never reaches its target. That is the business model.
I've been paying for liver fuel?
My gran takes hers with grapefruit juice.
Your gran is doubling her plasma concentrations.
It is mildly alarming that Pitar's grandmother has been running an accidental pharmacokinetic experiment for what I assume is several years.
Stop! We are going to cover this properly and correctly. Pharmacokinetics is what your body does to a drug. Pharmacodynamics is what a drug does to your body. Two distinct fields. Together, they explain why grapefruit juice can kill you, why your liver quietly sabotages your medication, and why the same dose that saves one person can kill another.
I did not know pharmaceuticals were this dramatic.
Every pill is a negotiation between the drug and every organ in your body that wants to destroy it. It's the most underappreciated war in medicine.
Subscribe now. The pharmaceutical industry runs on $2 trillion a year, and the concepts that justify every cent of it take 20 minutes to understand. This is the most expensive free information you will ever receive.
Everything that happens to a drug in your body follows 4 stages. Absorption, how it enters the bloodstream. Distribution, how it spreads once it's there. Metabolism, how it's chemically altered. Excretion, how it's eliminated. ADME.
ADME, right, like Adam, but...
Like ADME, absorption is the first stage, and the critical thing about oral absorption is the obstacle between the gut and the rest of your body. First pass metabolism.
Which is the liver thing.
Exactly. A swallowed drug dissolves, crosses the gut wall, and travels via the portal vein directly to the liver before it reaches your heart, brain, or any other target. The liver processes it immediately. What survives is what you actually get.
For oral morphine, bioavailability of 20 to 30%, 70 to 80% metabolized before leaving the liver, which is why oral morphine doses are 5 to 10 times higher than intravenous doses. The dose is calibrated to survive the gauntlet.
So IV morphine goes straight in at full strength, but oral morphine has to fight through the liver first?
Correct. Intravenous delivery bypasses all absorption barriers. 100% bioavailability by definition. Every other route loses something.
Some drugs lose everything. Insulin taken orally. The liver and gut proteases destroy it completely before it reaches circulation, which is why diabetics inject it.
And nitroglycerin, complete first-pass destruction if swallowed, which is why it's given sublingually, under the tongue, absorbed directly into systemic circulation through the mucous membrane, no liver involvement.
Nitroglycerin, like the explosive.
Same molecule, except your coronary arteries are less robust than granite, so the dose is somewhat lower.
It is mildly reassuring that pharmaceutical chemists considered that distinction.
Bioavailability is the formal term, the fraction of an administered dose that reaches systemic circulation unchanged. Oral drugs vary enormously. Some drugs simply cannot be given orally because the first pass effect would leave nothing.
So the route you take the drug determines how much actually works?
Entirely. And this is where clinical pharmacology gets consequential. A drug that works brilliantly intravenously may be completely useless as a tablet.
That's how a drug survives long enough to enter the blood. What happens after that is its own separate problem.
Distribution. Once in the bloodstream, a drug spreads through the body. How far it goes and where it ends up depends on 3 things: lipophilicity, plasma protein binding, and which biological barriers it can cross.
Lipophilic means fat-soluble. Fat-soluble drugs hide in fat tissue?
And in cell membranes, and in organs. This is captured by the volume of distribution, a measure of how extensively a drug disperses into tissue relative to plasma.
Chloroquine has a volume of distribution of hundreds of liters. The human body holds roughly 40 liters of total fluid. The difference is in tissue. Blood concentration drops fast after dosing, but the drug is absolutely still in your body, hiding in tissue, releasing slowly back into plasma.
Low blood level doesn't mean it's gone?
Exactly. And this matters enormously for dosing. Many drugs also bind reversibly to albumin and other plasma proteins. Only the free, unbound fraction is pharmacologically active. The rest is a reservoir.
The protein is holding inventory, releasing it to the active market on a controlled schedule.
That analogy is accurate. Drug-drug interactions at the albumin binding site are clinically relevant. If a second drug displaces the first from albumin, free concentration spikes suddenly. You can inadvertently double dose a patient without changing anything on the prescription.
It is mildly troubling that a dangerous drug interaction can be triggered by two molecules arguing over a protein.
The blood-brain barrier is the most selective obstacle. Tight junctions between specialized brain endothelial cells. Only small, lipophilic, non-ionized molecules cross freely. CNS drug design is so difficult, precisely because most molecules that have pharmacological activity are too polar or too large to get through.
That's why general anesthetics work in seconds, right? They're highly lipophilic. They cross immediately?
Propofol, intravenous, highly lipophilic, crosses the BBB within seconds of injection. Loss of consciousness in one arm brain circulation time, roughly 30 seconds.
One arm brain circulation time. That's a metric I didn't know existed, and now I'm scared of it.
Like a bouncer who only lets in small people who are greasy?
That is a functional description of the blood-brain barrier.
So the drug is distributed, it's reaching its targets, but the liver has not finished with it. The real metabolic work happens here, and this is where drugs start killing each other. Drug metabolism occurs primarily in the liver via the cytochrome P450 enzyme family. CYP3A4 alone is responsible for metabolizing roughly 50% of all clinically used drugs.
One enzyme, half of everything in a pharmacy?
One enzyme superfamily, technically, but yes. And CYP activity is not fixed. It can be induced or inhibited by other drugs and by food. This is the mechanism of most clinically significant drug-drug interactions.
Enzyme inducers ramp up CYP expression. Rifampicin in an antibiotic, Sparatus, is such a potent CYP3A4 inducer that it can halve plasma levels of cyclosporin, the immunosuppressant used in organ transplant patients. Patients on cyclosporin who start rifampicin have had transplanted organs rejected because the immunosuppressant was metabolized too fast to maintain effect.
An antibiotic caused organ rejection?
Via drug interaction, yes. In St. John's wort, a plant-derived supplement people take for depression, and is also a CYP3A4 inducer. The same interaction has been documented.
A herbal supplement caused organ rejection?
The supplement industry operates in a regulatory environment that does not require labeling these interactions. I find that frustrating from a liability standpoint, but admirable from a packaging standpoint.
It is mildly concerning that he has opinions on the packaging of something that caused organ rejection.
The inhibitor direction is equally dangerous. Grapefruit. Furanocoumarins in grapefruit irreversibly inhibit CYP3A4 in the gut wall. Not slow it down. Remove it. For drugs with narrow therapeutic windows that depend on CYP3A4 for clearance, a single glass of grapefruit juice can double plasma concentrations.
Double? From a glass of juice?
Certain statins, cyclosporin, some calcium channel blockers, some anticoagulants. For these patients, grapefruit is genuinely contraindicated. It is stated on the label.
People don't read labels.
My gran...
We know about your gran.
Let me add one more metabolic example because it demonstrates how elegant and dangerous this system is. Paracetamol. Most of it is metabolized by sulfation and glucuronidation, safe pathways. A minor fraction goes through CYP2E1 and produces a reactive metabolite called NAPQI. At therapeutic doses, NAPQI is immediately quenched by glutathione and excreted.
So there's a toxic byproduct that glutathione handles automatically?
At normal doses. In overdose, the primary pathways saturate. More drug is shunted through CYP2E1, NAPQI production outpaces glutathione supply, stores deplete, NAPQI begins binding covalently to hepatocyte proteins. The liver is damaged by the very compound it was processing.
The organ kills itself trying to handle the drug it was designed to handle. Mechanistically, I find this extraordinary.
Kelpie, your sense of beauty is alarming.
N-acetylcysteine is the antidote. It replenishes glutathione precursors. I have positioning notes on NAC as a consumer supplement.
It should not be sold as a consumer supplement to people who do not need it.
I'm going to do it anyway.
It is mildly reassuring that between his intentions and the market, regulators exist.
The liver's metabolized it, the kidneys are flushing it. And the rate at which they do that determines everything. How long the drug works, when you need another dose, whether levels accumulate over time. Yes, this is where half-life actually matters.
Excretion, drugs and their metabolites are primarily eliminated renally. Phase 2. Metabolism, glucuronidation, sulfation, adds polar groups to make compounds water-soluble, enough for the kidneys to filter and excrete. The liver converts, the kidneys eliminate.
Half-life, the time for plasma concentration to halve?
Correct, and it varies wildly. Aspirin, 15 to 20 minutes. Diazepam, up to 70 hours. Amiodarone, for cardiac arrhythmias, 40 to 55 days.
50 days?
Accumulates over months in lung, liver, and adipose tissue. Slow release back into plasma. If you need to stop it for a procedure or an interaction, you wait weeks. There is no shortcut. You cannot rinse it out. The drug is just there.
Steady state, when dosing rate equals elimination rate and plasma levels plateau. For amiodarone, takes months to achieve. You're dosing a patient for weeks before you know if the level is right.
Precisely. Steady state takes approximately 4 to 5 half-lives regardless of dose. The dose determines the level, the half-life determines the timeline.
And until you reach steady state, the drug is just building?
Accumulating, yes. Each dose adds to what remains from the previous dose. For drugs with long half-lives, inadequate monitoring during the accumulation phase is where toxicity hides.
It is mildly notable that the safest period to take a drug is also the period when most clinicians have the least data about what it is doing.
All right, the drug survived the liver, spread through the tissues, and now it's actually hitting something. What does hitting something look like in numbers?
We covered receptor binding and signaling cascades in episodes 7 and 8. What we need now is the quantitative layer, how drug concentration maps to pharmacological effect.
The dose-response curve, sigmoidal, S-shaped on a log concentration axis. At low concentrations, barely anything happens. In the middle, effect rises steeply. At the top, it plateaus. You can't extract more effect regardless of how much more drug you add.
So there's a ceiling?
That ceiling is Emax, the maximum achievable effect. And EC50 is the concentration producing 50% of Emax. EC50 is potency, how much drug you need to get an effect. Emax is efficacy, how large that effect can be.
Potency and efficacy are different things?
Completely independent. Buprenorphine, used in opioid use disorder treatment. Lower intrinsic efficacy than full opioid agonists, meaning lower Emax. But much higher receptor affinity, lower EC50, and much longer duration. It occupies the receptor and physically prevents full agonists from binding.
It's taking the parking space so the stronger drug can't pull in.
I'm using that analogy permanently.
The therapeutic index is the ratio of toxic dose to therapeutic dose. Wide therapeutic index, penicillin. You can dose generously with minimal toxicity risk. Narrow therapeutic index, lithium, digoxin, warfarin. Minor concentration changes carry major consequences.
Narrow therapeutic index is the market. Patients who need real-time plasma level monitoring, dose adjustments, alerts, and I'm calling it PharmaTrack.
Lithium, therapeutic plasma range, 0.6 to 1.2 millimolar. Below it, the psychiatric condition is not controlled. Above it, tremors, confusion, seizures, renal damage. Less than 1 millimolar separates normal from dangerous.
Less than 1 millimolar. That is a terrifyingly narrow target.
It is mildly notable that this is also a drug patients frequently decide to stop taking because they miss the mania it controls.
Pharmacogenomics is what makes this even more complicated. CYP-D6, the enzyme responsible for metabolizing roughly 25% of clinical drugs, is polymorphic. 7 to 10% of European populations are poor metabolizers. They have essentially no functional CYP2D6.
Same dose, different person, different outcome, because of their genes.
Codeine is a prodrug metabolized to morphine by CYP2D6. Poor metabolizers get almost no analgesia. The active drug is never generated. Ultra-rapid metabolizers convert it too fast and accumulate dangerous morphine levels from a standard prescription.
It is mildly noteworthy that a drug marketed as milder than morphine is, for a subset of patients, simply morphine with extra steps.
This is the argument for pharmacogenomic testing before prescribing. You remove the guesswork from a system that currently runs on population averages and treats individual variation as an afterthought. The full picture, PK and PD together, can be captured mathematically. PK-PD modeling uses systems of ordinary differential equations to predict drug concentration and effect over time for any dosing regimen.
I see letters and a fraction.
The simplest case, one compartment model, intravenous bolus. The equation is dCdt equals negative cow times C, rate of change of concentration equals the elimination rate, constant times current concentration. The solution is a mono-exponential decline. Concentration falls smoothly and predictably from the moment of injection.
Add a second compartment, peripheral tissues, and you get two-phase kinetics. A fast distribution phase as drug moves into tissue, then a slower terminal elimination phase. Add a pharmacodynamic model to the central compartment output, and you can simulate the time course of effect for any patient on any dose.
I'm going to do that.
Do what?
Differential equations on my show.
Your show?
Statistical Saturday. It starts tomorrow.
Patar, you have a show about statistics.
Differential equations, probability distributions, Bayesian inference, compartment models. I'll do this one.
Patar, you described standard deviation as how surprised the numbers are.
That is correct.
It is mildly inevitable that the person with the least apparent relationship to mathematics is the one who announced a math series.
I look forward to it,
How are you calm about this?
because I have been surprised by Patar before and been wrong about it every time. Where were we?
Could two-compartment model.
The practical application of PK-PD modeling is dose individualization, observing a patient's actual plasma levels, fitting them to a population-derived model, and adjusting doses in real time. This is already standard for narrow therapeutic index drugs in intensive care.
Bayesian dose individualization software. Someone has already built my entire slide deck.
Several companies, yes. One last pharmacodynamic concept that makes the clinical picture more complicated. Tolerance. Repeated drug exposure doesn't maintain the same response curve. It shifts it.
Chronic opioid exposure, mu-opioid receptor internalization, and downregulation. Receptor density at the cell surface falls. The EC50 shifts right. You need more drug to achieve the same effect. But the toxic concentration hasn't shifted by the same proportion. The therapeutic window narrows from one side.
The gap between works and kills you shrinks the longer you use it?
That is the mechanism underlying escalating overdose risk in chronic opioid users. The biology that initially protected them from overstimulation becomes the biology that erodes their safety margin.
Like building a taller wall and then finding out the water grew too.
I don't know what that means, but I felt it somewhere real.
Tachyphylaxis is rapid tolerance. Hours, not weeks. Nitroglycerin infusions develop tolerance within 24 hours, which is why continuous nitrate therapy includes nitrate-free periods. Nasal decongestant sprays, rhinitis medicamentosa. The rebound congestion is worse than the original symptom, caused by upregulation of the pathway the drug was suppressing. The drug creates the condition it was treating.
And then you buy more. The market self-sustains. I've always respected the structure of it.
It is mildly impressive that he finds it admirable.
Patar, do the thing.
You swallow the drug. The liver sees it first, takes the initial cut. Whatever survives gets distributed based on how fat soluble it is and whether proteins hold it. The liver keeps converting it. The kidneys flush what's left. While all of that is happening, whatever is free in the blood is finding its targets, pushing up and down a response curve, staying inside or outside a window. How much gets through, how long it stays, what shape the concentration profile takes, that is pharmacokinetics. What happens at the target when it arrives, that is pharmacodynamics. One is the journey, the other is the destination. Most drugs that fail in development fail at one of those two things.
Most drugs that fail in development fail at one of those two things. Patar, how do you do this?
That was the most accurate encapsulation of PKPD I have heard, including from peer-reviewed sources.
She included drug development failure in the summary, unprompted, the part that takes medicinal chemists years to fully internalize, that you can have perfect pharmacodynamics and useless pharmacokinetics, and the drug will never reach a patient. She just said it.
It is mildly insulting to everyone in this room with a relevant degree.
That goes on merchandise. Most drugs fail at one of those two things. Coffee mug, $28. Sign print, $80.
Okay, final exam. I have been changed by this episode. I am ready.
You were visibly shaken by the grapefruit segment.
I was transformed by the grapefruit segment. 3 questions, Dr. Seeley.
Pause the video. 3 questions. Answer before pressing play. No skipping. Question 1. Oral morphine requires 5 to 10 times the intravenous dose. Why? A. It is absorbed more slowly through the stomach. B. First-pass hepatic metabolism substantially reduces bioavailability. C. The kidneys filter it before it reaches the liver. D. Morphine is chemically unstable at gastric pH. Question 2. A drug with a half-life of 10 hours reaches steady state after approximately how long? A. 10 hours. B. 24 hours. C. 50 hours. D. 100 hours. Question 3. Grapefruit juice inhibits CYP3A4, causing plasma levels of co-administered drugs to A. Decrease due to reduced intestinal absorption. B. Remain unchanged. Grapefruit only affects renal clearance. C. Increase due to reduced first-pass and gut wall metabolism. D. Decrease due to enhanced protein binding.
Take your time.
Question 1, I said B, first pass, hepatic metabolism. The portal vein sends everything from the gut straight to the liver before the rest of the body sees it. I knew this. I got it.
Correct. Portal circulation, pre-systemic extraction, classic, clean.
Answer B. The entire sublingual, transdermal, and intranasal drug delivery industry exists as a direct commercial response to answer B. Billions of dollars of innovation, all trying to route around the liver.
Question 2. 4 to 5 half-lives to reach steady state. 10 hours times 5 equals 50 hours. The answer is C.
I said 24. I divided something. I don't know what I divided.
He estimated by feel.
It is mildly predictable that the person most energized about this episode performed the arithmetic incorrectly.
Squeven, I am already down. You do not need to do this.
Question 3. Grapefruit furanocoumarins irreversibly inhibit CYP3A4 in the gut wall. First-pass metabolism and gut wall metabolism both decrease. More drug reaches circulation. Plasma concentrations increase. The answer is C.
I spent part of this episode thinking about using controlled grapefruit furanocoumarin administration to deliberately ablate CYP3A4 in research subjects and study the effect on narrow-window drug pharmacokinetics in the absence of gut wall metabolism. As science, not as a treatment.
Standardized grapefruit extract. Quantified furanocoumarin content. Marketed as a bioavailability enhancer for supplement stacks. I will be wealthy.
You will not.
2 out of 3, assuming the group answered as a collective and Bobby was one of the 3. It is mildly appropriate